Okay, so chalo, let's start. So first of all, considering this as a revision session, the first thing I just want to add a note is the mandatory checklist for your dental histology is definitely, I recommend dental pulse synopsis or even your power play books synopsis is very nice. Okay, so I want you to keep that as a primary checklist. So whatever you learn from this quick revision or whatever the smart videos that are available, you can consider them as an add-ons. Wherever you feel like the concepts are missing, you can add on directly into the dental pulse synopsis. And the previous Pro Live class already available. I told you to finish it off and try to do as many MCQs as possible. But once you come to the last reading, means maybe like, for example, people planning to prepare. Okay, so in the last 10 days, few of them, they plan 10 days revision. Means 10 days before exam, they try to revise all the subjects. Few of them, they plan 2 weeks revision. Either it is 10 days or 14 days, basing upon your convenience. Okay, because you should not compromise in the revision in the last. So in this 10 days or 14 days, whatever you're going to plan in the last 10 days or last 14 days, basing upon the convenience, okay, your dental histology and dental anatomy, both dental histology as well as dental anatomy, the revision should not be more than 3 to 4 hours each. Okay, means your stuff should be organized properly. Okay, that is your dental pulse synopsis or PP book synopsis plus add-ons is the only thing that you are going to revise. Right? Clear, right? So I have given a plan like how to revise dental anatomy, dental histology in the last 10 days plan or in the last 14 days plan. You should allocate 3 to 4 hours only. Totally, it should be 8 hours. You should finish both of these revisions in 8 hours in one day. Okay, means for example, you're reading 12 hours. So 8 hours, you need to finish these 2 subjects and you need to start a next subject. Then only you can have a proper, beautiful preparation in the last 10 to 14 days. Clear, guys? Clear about this revision plan before you go to exam? Okay, so chalo, without wasting any time, it is probably a one-way class, quick revision wala, and here and there I'll be asking questions integratedly and I want you to answer quickly on the chat box. Shall we start without wasting any time? So first and foremost thing is formation of dental lamellae. So normally, okay, your oral cavity and your foregut will be like this. And this oral cavity foregut will be separated by a membrane called as buccopharyngeal membrane. At 27th week, at 27th day, what is going to happen? This buccopharyngeal membrane is going to rupture. So there is a communication that is formed between the foregut and your oral cavity. So foregut and oral cavity are communicated by the breakdown of buccopharyngeal membrane at 27th day. So this is very, very important. 27th day. Then the next important thing, okay, the proliferation of your oral ectoderm due to the neural crest cells is going to occur at 6th week. 6th week is again a very, very frequently asked question. So this resulting in formation of a band called as primary epithelial band, which is going to split it into 2 parts. One is dental lamellae, where most of your dental structures are going to form. And second one is vestibular lamellae. So vestibular lamellae is going to give rise to oral vestibule, whereas your dental lamellae is going to give rise to all your teeth. Okay, both primary as well as the permanent teeth. Sometimes some areas of your dental lamellae will get degenerated. So those are called as remnants of your dental lamellae degenerated. They are called as cell rests of rhesus, which in future can give rise to formation of few cysts that we'll be discussing in oral path and oral medicine. Clear, right? So most important points are 27th, the rupture of buccopharyngeal membrane occurs at 27th day, a very frequently asked question. Then the proliferation of your oral ectoderm due to the neural crest cells occurs at 6th week. Okay, so dental lamellae gives rise to dental structures and vestibular lamellae gives rise to oral vestibule. And one important aspect about the tooth development is Okay, so which structure in teeth is formed from ectoderm only? Ectoderm. What is ectoderm? Which is found from ectoderm only? Yes, it is enamel. They can ask you, enamel is formed from ectoderm, okay, or ameloblast, which is the one, ameloblast is going to form from ectoderm. Ameloblastoma is going to form from ectoderm. So all of these are formed basically from ectoderm. So these are generated only once in the entire life. Okay, so once in entire life, they cannot be regenerated again and again. So for example, if they're asking a question, tooth is formed from, enamel is formed from ectoderm. Tooth is formed from. So what is your answer? Tooth is formed from ectomesenchyme. Tooth is formed from ectomesenchyme. Enamel is found from ectoderm. Okay. Then comes the stages. So most of you are familiar regarding the stages. Okay. What are the stages? Sequence of stages they can ask you. Bud stage, cap stage, bell stage, which is divided into early bell and advanced bell stage. So the next question frequently asked is layers in each stage. Okay. Particularly, for example, like cap stage layers. A cap stage has 3 layers. Layer 1 is outer enamel epithelium. Layer 2 is stellate reticulum. Layer 3 is inner enamel epithelium. Next one, early bell stage. Early bell stage is going to have 4 layers. Outer enamel epithelium, stellate reticulum, stratum intermedium, and inner enamel epithelium. Advanced bell stage is going to have 5 layers. Outer enamel epithelium, stellate reticulum, formation of future DEG, and stratum intermedium and inner enamel epithelium. Okay, so they can ask you the layers, arrange the layers in the sequence, or they can ask you arrange the stages in the sequence. Coming to bud stage cell and their shape, they can ask you. So for example, bud stage, the peripheral cells are low columnar cells, whereas the central part, okay, the central part is going to have the polygonal cells. Coming to outer enamel epithelium is basically low cuboidal cells, whereas stellate reticulum, they are star-shaped cells. Stellate reticulum is going to have star-shaped cells. So normally, during the initial phase, stellate reticulum is going to have polygonal cells. Okay. Due to osmotic difference, okay, because of the movement of the fluid, these polygonal cells in future, they modify into star-shaped cells. Because of star shape, they are called as stellate reticulum. Okay, what type of cells are seen in the case of stellate reticulum? Star-shaped cells. Or they can ask a question, during the initial formation, what type of cells they are seen in the case of stellate reticulum? Polygonal cells. Polygonal cells will be differentiated due to osmotic pressure variation into star-shaped cells. Okay, again, low cuboidal cells in the outer enamel epithelium. Okay, star-shaped cells in the case of stratum reticulum, and squamous shape of cells in the case of intermediate. Same as apple, right? Clear? I hope you are clear till this point. So regularly asked, which enzyme is increasing in stratum reticulum and stratum intermedium? Anyone? Which enzyme is increasing stratum reticulum, stratum intermedium? Yes, right. Yes, right, you guys. Alkaline phosphatase. Okay, very frequently asked question. Stratum reticulum, stratum intermedium. They are, what enzyme is increased? Alkaline phosphatase. Alkaline phosphatase is basically associated with formation. Okay, many formation cells like osteoblasts, chondroblasts, osteocytes, and all these are formation cells where your alkaline phosphatase will be increased. Okay, resorption cells, which enzyme will be increased? In resorption cells, which enzyme will be increased? So in resorption forms, yes, right, perfectly right. In resorption forms like clasts, osteoclasts, odontoclasts, acidic phosphatase will be increased. Means they are active at acidic pH. They are active at acidic pH. Can anyone tell me what is the pH at most of your osteoclasts will get activated? pH at most of your osteoclasts. Definitely, it is an acidic pH. Okay, preferably a pH of less than any value, less than 4. Okay, so in textbook it was given as 2.5 to 3, around 2.5 to 3. Most of your osteoclasts are going to get activated. Okay, next I want to focus on the next important area. So the events which takes place in each type of stage, they can very frequently ask. One important thing is dental papillae. Dental papillae formation can occur. Okay, can you tell me what is dental papillae gives rise to which structures? Dental papillae is DP. Dental papillae gives rise to D for dentin. Very good. P for pulp. So dental papillae gives rise to dentin and pulp. Okay, next one is dental follicle. Dental follicle. Dental follicle means, for example, you consider this as a teeth. Follicle is something which is surrounding the teeth. Okay, so dental follicle, it gives rise to all the structures surrounding the teeth. What are the structures surrounding the teeth? Yes, right. Very good. Cementum, PDL, alveolar bone. So dental follicle gives rise to structure surrounding the teeth, that is your cementum, PDL, and alveolar bone. And dental papillae gives rise to DP, that is dental pulp. So that's dentin and pulp. Okay. Next one. I hope you are familiar with these terms. That is enamel, enamel knot, enamel cord, enamel septa, enamel navel, and all these things. So these structures are formed in which stage? These structures are formed in which stage? Okay, all are related to enamel, right? Means you can consider them as enamel complex. Easy to remember, no need to confuse. Enamel complex. What is this enamel complex? All structures of enamel together form a complex. Okay, right? What are these? Knot, cord, septa, navel, all are together form complex. So, which stays complex? C for C, cap stays. Enamel complex. All these structures are formed in complex C for C, cap stays. Now, early Bell stage. What happens in early Bell stage? I want to add one important point here. Already discussed which enzyme is more in the case of your stratum intermedium. Already discussed, that is your alkaline phosphatase. Repeated so many times. Similarly, okay, so your stratum intermedium, which is very rich in glycogen, okay, that is very helpful in the formation of enamel. Okay, very, very important. Please do make a note of this. Okay, which layer in early Bell stage is very, very rich in glycogen that helps in enamel formation? What is the layer? Yes, that is your stratum intermedium. Very good. Okay, next, what happens? Your cellulate reticulum, okay, reduces the distance. Means cellulate reticulum, which is present. Okay, so what is going to happen? The cellulate reticulum is going to collapse, and it is going to reduce the distance between the inner enamel epithelium and to the capillaries of outer enamel epithelium. Okay, so inner enamel epithelium is there. So cellulate reticulum damages, and it decreases the distance between the outer enamel epithelium and inner enamel epithelium. Outer enamel epithelium is laid down into folds in between of which of the mesenchyme of your dental sac condenses to form papillae, which is rich in capillaries and which is the main supply of your nutrients. Blood supply is required, sir. Blood supply is going to form nutrients. Okay, now the next question is, okay, HERS. What is HERS? Yes, HERS is basically going to contain outer enamel epithelium. It's going to contain two layers: outer enamel epithelium, inner enamel epithelium. Where is this HERS formed? Which location it is formed? Okay, the HERS is basically formed at cervical portion. So clearly given right here, the HERS is formed at cervical portion. Okay, they consider it as cervical loop. HERS is at cervical loop. What are the two layers in HERS? What are the two layers in HERS? The two layers in the HERS are outer enamel epithelium. Okay, and the second one is inner enamel epithelium. HELS is going to have two layers. One is outer enamel epithelium, and second one is inner enamel epithelium. Okay, clear, guys? Just a second. Please don't write on my screen because this is the recorded version and it looks very, very odd and irritating for others. Okay, please. Please don't touch my screen. Please, please. Kind request, please. Okay, chalo. So I'm jumping RS. What is the use of HERS? What is the use of this HERS? HERS will determine you the position of root, number of roots and everything. It is basically inclined to roots. Okay, so dental papillae gives rise to which structure? DP. Dental papillae gives rise to dentin and pulp. Dental follicle gives rise to surrounding, all surrounding, PDL, alveolar bone. Okay, cementum are surrounding. So dental follicle gives rise to that. Okay, right? Okay, right. So the next important area is okay, the composition. Okay, the composition of enamel and dentin basing upon the So check out whether they're asking by weight or whether they're asking by volume. Okay, so by weight or by volume. So what is going to happen? Okay, right? So this is very, very important. So normally it is 96 or 97 by weight. For example, if they're asking by volume, the percentage of inorganic content is 92%. So highest inorganic content is present in the enamel. Okay, and question which is previously repeated in the examination is percentage of water in dentin by weight. Percentage of water in dentin by weight is 10%, and percentage of water by volume in dentin is 22%. So I want you to remember water percentage. Okay, what is this? Enamel and dentin. The answer is 1, 6, 10, 22, right? So it is by weight water, by volume water in the enamel, by weight water in the dentin, by volume water in the enamel. Clear, right? Guys, clear? Okay. So can anyone tell me, integrated question, how much amount of loss of water will be there in dentin after root canal therapy? How much amount of water is lost in the dentin after root canal therapy? Loss of water in dentin after RCT. How much? Yes, very good. Answer is 9%, is previously repeated in the examinations. Okay, right? So according to this, which is having more water, dentin or enamel? Yes, right. So dentin is having more water. So that is the reason why bonding to dentin is difficult. Okay, so what came into existence for a good bonding of dentin? So we regularly using dentin bonding agents. So what are the bonds which are present in the dentin bonding agents? So dentin bonding agents are having two bonds, right? One is hydrophilic bonding, and second side, they are hydrophobic bonding, right? Hydrophilic bonding and hydrophobic. Hydrophobic bonds to which structure? Dentin is having water, so one side is going to bond to the dentin. So hydrophilic is going to bond to the dentin. Hydrophobic is going to bond to the resin or composite, your DM concept. Clear? Okay, chalo. I'm moving to the next one. Right. So one very important aspect that I want to stress about your enamel is the only structure in the human body which is already calcified before the process of calcification start. Okay. So they can ask you how much amount of enamel is calcified initially without maturation. Okay, without maturation, how much amount of enamel is calcified? 30% is. Okay, 29 to 30% is basing upon the references. Sometimes it may be 29 to 30% is the amount of calcification that is seen in the initial calcification of the enamel. Okay, right? So after maturation, okay, completely calcified. Whereas in the dentin, it is uncalcified matrix will be there. Cementum will be uncalcified matrix will be there. Okay, the next one is, enamel is going to have hydroaccepted crystals. So the crystals which are present in the enamel are 50 to 500 times. It varies reference, right? It may be Orban's, it is number may be different, but basically the main important thing I want you to make a notice, it is larger in size when compared to the crystals which are present in the dentin. So when compared to the crystals of the dentin, enamel crystals are larger in size. And a very, very unique point about the bone hydroxyapatite crystals are lengthwise bone hydroxyapatite crystals are lengthwise, they are more. Okay. Whenever your enamel is treated with fluoride, okay, what are going to form? Fluorapatite and fluorohydroxyapatite will be formed. So this fluorohydroxyapatite are larger crystals when compared to normal hydroxyapatite. So what hydroxyapatite is present in the enamel, whenever you treat with fluoride, they form fluorohydroxyapatite. These crystal sizes are larger in size. Okay, we have discussed this concept in operative dentistry. Okay, when I'm talking about the mechanism of mineralization or mechanism of maturation, okay, it is almost same in all hard structures of teeth. That is enamel, dentin, cementum, it is same, and it is almost same in the case of your AB, that is alveolar bone also. Clear, right? Okay. The most important thing we have already discussed is enamel is ectoderm. Enamel has hydroxyapatite crystals. They are hexagonal in shape. They are long. They are irregular hexagonal. Okay. The only one structure in the teeth which does not have collagen. What is the structure in the teeth which does not have collagen? Is enamel. Enamel does not have collagen. Enamel does not have nerves. Enamel does not have blood vessels. So blood vessels are absent, collagen is absent, and nerves are absent. So all these are absent in enamel. So all the structures are absent in the enamel, right? Clear, guys? Clear till this point? Okay, chalo. So most of you are familiar regarding this. Okay, so the modulus of elasticity is high for enamel or dentin? Modulus of elasticity is high for enamel or dentin? DM question. So modulus of elasticity is high for enamel. And among the enamel, which layer is having the highest modulus of elasticity? Yes, these are the lines. The surface, at the surface, the modulus of elasticity is higher. At the surface, the modulus of elasticity is higher. Okay. So can you tell me what is the specific gravity value of enamel? So what is the specific gravity value of the enamel? The specific gravity value of the enamel is 2.8. Dentin, anyone? Dentin, what is the specific gravity value? Yes, perfectly right. Dentin has specific gravity value 2.2. Saliva, anyone can tell me the specific gravity value of saliva? Very good, 1.008. Nitrous oxide, specific gravity of nitrous oxide? Yes, perfect, 1.53. And now I'll be asking one question. Specific gravity of gold, anyone? Anyone can tell specific gravity of gold? No one? Specific gravity of gold is 19. Mercury? Mercury, anyone? Yes, it is clearly given. Mercury is 14 times denser than water. Okay. It's around like 13 to 14. Okay, right. DM part. Okay, right. So the next important aspect I want to stress on is the value. Okay, that is temperature resistance value of your enamel. That is 5 to 13 hex. And electrical resistance value is 10 to the power of 5 to 10 to the power of 15 ohms. Clear, guys? And enamel is semi-permeable. Okay, enamel is semi-permeable, partially or completely permitting two important substances, that is 14 carbon labeled urea and iodine. 14 carbon labeled urea and iodine and peroxides. Okay, very frequently asked question. Enamel is permeable to peroxides. Enamel is permeable to peroxide. Can you tell me one more layer that we have discussed in the histology? That is your perio part, which is semi-permeable. One more layer in perio, which is semi-permeable. What is that layer? One more layer. Yes, same. Easy to remember, right? Semi-permeable. Circular epithelium, right? Circular epithelium. Circular epithelium is semi-permeable, right? Clear, done. I'm moving to the next part. Yes, guys, you are familiar. Coming to the composition, we have already discussed. Inorganic content is largest by weight, that is around 96 to 97%. And the rest of the substances are organic substances and water, which occupies 4%. Coming to your organic content has some unique proteins. Okay, some unique proteins. What are those proteins? Called as amelogenesis and non-amelogenesis. Amelogenesis are low molecular weight proteins which occupy 90% of enamel proteins. They are basically hydrophobic. Okay, they are basically hydrophobic and they are rich in, okay, they are rich in HPGL amino acids. They are rich in HPGL amino acids. Recently only we have done biochemistry, right? We have done what are essential amino acids, what are non-essential amino acids, what are semi-essential amino acids, the same amino acids. HPGL is related to amelogenesis, which are hydrophobic and they occupies 90%. Okay. The next goes, Swaroop, please don't do anything on my screen. Please. Okay. Next one, non-amelogenins. Non-amelogenins, which are going to occupy 10%. Okay. So what are the proteins that are present in non-amelogenins? They are ETA. They are ETA. Okay. So when coming to the amino acids, what are the amino acids which are rich here? GAS. So tell me, what is the code for amino acids which are rich in amelogenins? What is the code for amelogenins? Amelogenesis is HPGL. You can remember as HP gas limited. Both are gas. Amelogenesis name HPGL. HP gas, HPGL gas limited. Okay, not within the 2 hours of duration. Okay, right? Okay. Then comes amelogenesis, hydrophobic, 90% is low molecular weight, HPGL. Non-amelogenesis, high molecular weight, okay, occupies 10%, and the code is GAS. Okay, and you know this hydroxyapatite formula, very frequently asked, Ca10PO4 to the power of 6 and OH4 to the power of 2, and it is regularly irregular hexagonal in shape. Okay, right? Clear? Okay, the next comes, underline points are very, very important. During the formation, magnesium is going to replace the calcium and carbonate is going to replace this hydroxyl ions. Because of this replacement, okay, there will be destabilization, the poor fit of these ions. So what happens finally? Thus, the core of the crystals, okay, the core, okay, you know, hexagonal, right? Thus, the core of the crystals means the center part of the crystals is rich in magnesium and carbonate. Okay, the central part is rich in magnesium and carbonate. Okay, and that is the reason why there is a greater solubility of acids in the center part than the periphery. Okay, so central part is rich in magnesium and carbonates. That is the reason why it is more dissolved when compared to the periphery part of your hexagonal crystalline structure. Okay, then the dry weight, the most predominant molecule that is present is carbon dioxide, that is 34.4% you will be having carbon dioxide, and you'll be having 36.6% of calcium and 17.7% of phosphorus. So which molecule is more? Okay, molecule which is more is oxygen. Next comes to the formation. Okay, during the formation, basically it is acidic. Okay, and then it moves to neutral, and then it moves to basic. So it is acidic, neutral, and finally it is the basic or alkaline. This is how the pH is that is going to change during the enamel formation. And we know that the pH is going to be controlled by a agent called as buffering capacity. So the buffering capacity during the pH regulation is maintained by carbonic anhydrase. And which types of carbonic anhydrase? Very important. That is Ca2 and Ca6. Carbonic anhydrase 2 and carbonic anhydrase 6 are main regulators of pH during the formation of enamel. Okay. Okay, clear guys? So most of the things you are familiar. Enamel rods or enamel prisms, they are lowest, that is 5 million in the case of your lower lateral, and they are highest in the case of your upper first molar. Okay, so pulpal volume or pulpal size is highest for which teeth? The volume of pulp. Normally, the total volume of pulp is 0.38 cc. Pulpal volume is highest for which teeth? Someone is telling canine. No, not canine. It is maxillary first molar. The same teeth is having the highest pulpal space. Root surface area. Root surface area also called as pericemmental area. Antisla, FPD, selection of abutment, is highest for which teeth? Root surface area also called as pericemmental. Yes, right. The question is again the same for all these, like highest number of enamel rods, highest number of pulpal space, root surface area or pericemmental area is maximum for all these questions. The answer is upper first molar. Okay. So which teeth is very close to maxillary sinus? Which teeth is very close to maxillary sinus? Which teeth is very close to maxillary sinus? Yes, the answer is same. Maxillary first molar. Okay. One more twist in the question. During development, which teeth is very close to maxillary sinus? During development, which teeth is very close? Yes, during development, if they're asking, your answer should be maxillary canine will be close to maxillary sinus. But in a normal individual, which teeth will be close to maxillary sinus is maxillary first molar. Can you tell me maxillary antrum dip is present between which teeth? Maxillary antrum dip. Maxillary antrum dip is present between which teeth? Maxillary antrum dip. Yes, very good, Kirti, very good. It is between the second premolar and first molar. Very good. Right? Very good. Chala, I'm moving ahead. And you guys know that these enamel rats are oblique in direction. They have a wavy course. Okay. And that is the reason why they are greater than the thickness of the enamel. Enamel thickness is highest at. Enamel thickness is highest at. Yes, enamel thickness is highest at cusps. Okay. So what is the shape of your dentinal tubule? These are oblique. Dentinal tubules? Yes, dentinal tubules are S-shaped. Dentinal tubules are S-shaped. Very good. Okay, then coming to the structure, the diameter of the rod is 4 micrometers. It is hexagonal, irregular, fish-shaped. Fish-shaped is recent INICET question. The same diagram was given. You can say fish scales. Okay, they are appearing like a fish scales. The diameter of the rods increases from dentino-enamel junction towards the enamel. That will be in the ratio of 1:2. And submicroscopic structures, keyhole or paddle-shaped prisms. Okay, so we have already discussed the diameter is, the breadth is 5, length is 9. Okay, so it's very simple, like 9 is equal to 5 plus 4. Okay, 9 is equal to 5 plus 4. We are also made it as diameter is 4, breadth is 5, length is 9. Easy, right? 5 plus 4, 9. So 5, 4, 9 are the values that you have to make a note regarding this enameled rods. Direction of enamel rods is important. Very frequently asked question. The direction of enamel rods in deciduous teeth. Okay, in almost all the areas they are same, but in the case of cervical 1/3 they are different. In the case of permanent teeth they are apically directed. In the case of cervical teeth they are occlusally directed. Striations, enamel rods built up segments separated by a dark lines that give striated appearance. The uniform length of 4 microns is seen. Grand enamel, you are familiar, right? They can ask you diagram-based question also. Grand enamels are most commonly seen over the cusps of the teeth, okay, at which the enamel rods appears to be twisted around each other. Okay, this makes enamel very strong at those areas, and that is the one which is going to give resistance to the fracture of the enamel. Okay, so enamel is going to have, do you consider enamel as brittle? Is enamel brittle or not? Whatever. Yes, enamel is brittle. Along with enamel, okay, enamel is brittle. Okay, right, very important. There is a small correction regarding this in your PP book synopsis. D for D. Okay, dark zones, diazones. Okay, okay. Light zones are parazones. Easy to remember. Dark for D. What is the angle between these two? What is the angle between these two? The angle between the diazones and parazones. What is the angle? Yes, the angle between these two is 40 degrees. So, okay, chill, I'm moving ahead. Incremental lines of radial edges. Okay, so they are going to be brownish bands and successive apposition of the layers of the enamel that is found from the DEJ to the surface, deviating towards the occlusal surface. Whereas in the case of transverse section, you are going to see it as a concentric circles. So what is neonatal lines? Where do you see neonatal lines? Neonatal lines are regularly seen in the case of deciduous teeth and the first permanent molars. So neonatal lines are basically like, they are going to give an information about the metabolic supply for us during inside the mother and outside the mother. Outside the mother, environment will be different. So those lines will be different. Inside the mother, environment will be different. Okay, those lines will be different. So neonatal line is the one which is demarcating, showing the differences between the environment inside, environment outside, which is normally the patterning of these rods. Clear? Okay, the next comes is structureless enamel or prismless enamel. The thickness is about 70 mm thickness. It is most commonly seen in the case of 70% of permanent teeth and all deciduous teeth, most commonly seen in the cervical area. Okay, so this is called as aprismic enamel. Anything about aprismic enamel? Any clinical consideration about aprismic enamel that we have discussed during pedo or that we have discussed during operative part? So according to the new concepts, the itching time, yes, Pavani is right. So itching time is basically nowadays, according to the recent modifications, the itching time of primary teeth is equal to that of the permanent teeth. But in old concepts, you have few questions like itching time of primary teeth is more than old concept. What is that old concept? Primary teeth itching time is more than the permanent teeth. Why? What is the reason? The primary teeth itching time is more than the permanent teeth. The reason is presence of aprismic enamel, which is more in the primary teeth when compared to that of the permanent teeth. But now the latest concept. So what is the latest concept of itching time? The latest concept of itching time is clearly telling that the itching time of the primary teeth is equal to itching time of the permanent teeth. Clear? Clear, guys? Okay, very good. So perikymata are wavy like grooves, okay, believed to be the external manifestations of retiridges. So very frequently, so many times repeated in the exam, external manifestations of striations of retiridges is called as perikymata. So at CG, it is 30 per millimeters. At incisal or occlusal area, it decreases. Okay, it decreases. It is 10 per millimeter. Okay, then comes the enamel cuticle. Okay, so enamel cuticle is called as primary enamel cuticle or Neck-Smith membrane. Okay, so many times given in the exam. Okay, it has a wavy course. It is secreted from the ameloblast when the enamel formation is completed. Means ameloblasts are going to form the enamel in the last minute. They secrete a layer. That layer is called as primary enamel cuticle. Why they secrete this? They want to protect the enamel. So ameloblast is going to secrete enamel, and finally they form a layer that is called as primary enamel cuticle, which is going to protect the entire enamel. That is the last job done by ameloblast. Okay, so ameloblast is originated from which germ layer? Yes, ectoderm. So pellicle. So we have a similar pellicle, right? In operative dentistry also, pellicle, materia alba, and followed by plaque. Plaque get calcified to form calculus. Okay, so in an erupted teeth, okay, so pellicle will be there, which is basically the precipitation of salivary proteins. Salivary proteins, they form a protective layer called as pellicle on a recently erupted enamel. Okay. Enamel lamellae. So what are these enamel lamellae? Enamel lamellae are thin leaf-like, L for L, L for L, leaf-like. What are ribbon-shaped structures? What are ribbon-shaped structures in enamel? Ribbon-like structures, if they ask. What is your answer? Ribbon-like structures are tufts. Leaf-like structures? Leaf-like structures are lamellars. Okay. So what is this leaf-like structures that extend from enamel surface and they move? This is enamel surface and they are moving towards dentino-enamel junction. They are moving down. So these are called as thin leaf-like structures that are extending from enamel surface and moving towards the dentino-enamel junction. So these are called as enamel lamellae. So they are basically A, B, and C. Which are most common? God is so great, huh? Which are most common? Yes, most common are C for common. Which are most common? The most common are C. They are basically filled with organic material from the saliva, and they are most commonly seen in the case of erupted teeth. You can remember it as completely eruption. C for complete, C for common, completely erupted. Organic material from saliva, completely erupted and reach into the dentin means complete, right? Completely they reach the dentin. Okay, so these are the most commonly asked questions area. The next one is B for degenerated cells. Degenerated cells are seen in the unerupted teeth. Okay, they also reach into the dentin, but they are less common. Next one, A is poorly calcified enamel rods, unerupted teeth, but these are restricted to the enamel only, less common. Okay, which is most common type? Which is most common type? Yes, most common type are C type, which is the only type which is seen in the case of erupted teeth, completely erupted. Most commonly seen in the completely erupted, yes, right. Which is formed from the organic matter from the saliva. Organic matter from the saliva. Yes, perfectly right. That is C type. Degenerated cells are seen in B type, which is the only one that is restricted to enamel. Only one that is restricted to enamel and poor calcified is A type. Which structures are leaf-like? Leaf-like structures are L for L, leaf-like lamella. Okay, then our ribbon-like fellow came. Who is the ribbon? Ribbon is tree. You can remember it as tree tufts. So enamel tufts. Okay, diagram-based question was previously given. Now this fellow comes from opposite direction. Arise from dentino-enamel junction and is trying to reach the enamel. Previously, it is arise from enamel and trying to reach the dentino-enamel junction. This fellow arise from dentino-enamel junction and trying to reach the outer surface. Okay, right. So these are narrow ribbon-like structures, and these are hypocalcified enamel rods. Okay, they contain hypocalcified enamel rods and they contain interprismic substances. They contain interprismic substances. If you want, you can make a note of this value. That is straight away from the textbook. Okay, right. The next one is odontoblast processes and enamel spindles. So odontoblastic processes passes through a process across the DHA and they enter into enamel. They appear dark in the transmitted light and they are most commonly seen in the case of your cuspal tips. Next, the junction. Okay, you can see the junction. The junction is scalloped. Okay, so it is scalloped and the convexities of these scallops are directed towards the dentin. D for D, directed towards the dentin. Dentino-enamel junction, convexities are directing towards the dentin. Very simple. Okay, right? Okay, then comes the epithelial enamel organ. The epithelial enamel organ is originated from the stratified epithelium of the primitive oral cavity, and it is going to contain outer enamel epithelium, stellate reticulum, stellate intermedium, and inner enamel epithelium. The inner enamel epithelium is called as ameloblastic layer. This we have already discussed during our stages. Okay, now we have already done. Okay, so outer enamel epithelium is what shaped? Previously done. Outer enamel epithelium is cuboidal shaped. Can you tell me during the initial phases, your stellate reticulum is what shaped? During your initial phases, your stellate reticulum is what shaped? Yes, during your initial phases, our stellate reticulum is polygonal shape, but after osmotic difference, it become star shape. Normally, if they're asking stellate reticulum shape, star shape. Okay, stratum intermedium also we have discussed. Stratum intermedium is basically flat to cuboidal shape. Inner enamel epithelium is columnar shape. Outer enamel epithelium, very frequently asked question. Outer enamel epithelium cells are cuboidal in shape, whereas inner enamel epithelium cells are columnar in shape. Okay, they differentiate into ameloblast and they form enamel. Okay, and they plays a very, very important role in enamel production. These acts as a buffer against the physical forces. Okay, stellate reticulum, okay, it's like a cushion which is going to act as a buffer against the physical forces. And the outer enamel epithelium is going to supply food for this ameloblasts. Guys, clear? Very important points these are. Diagram based. I hope you can answer this. Okay, so cap stays, bud stays, bell stays, and all these are diagram based. Very, very important. So they can mark you and I ask you to identify which layer it is. Dental lamellae, outer enamel epithelium. Inner one is inner enamel epithelium. The projecting one is called as dental papillae, which is going to give rise to your dentin and pulp. Okay, and the surrounding one is dental follicle, which is going to surround the teeth. That is your pedial, cementum, and areolar bone. and cervical loop is the position at which you're going to have your HERS, okay, which is going to contain only two layers, that is outer enamel epithelium, inner enamel epithelium, whereas your reticulums, both the reticulum, stratum, and intermedium are absent in the case of your cervical loop, which gives rise to formation of HERS, that is your root and number of roots, shape, size, and number of roots. Guys, clear? Am I going a bit fast? Shall I reduce the speed, or can I go with the same speed? Yeah, okay, very good. The next comes is the life cycle. Okay, life cycle development of enamel, how it's going to occur. We know that the formation of enamel matrix, during the enamel matrix itself, enamel is having 30% of minerals in it. Then after, what is going to happen? Mineralization and maturation will occur. The 30% will be converted to 100% of minerals. This is going to be that. And you have how many stages of life cycle of an ameloblast? You are going to have 6 stages. They are morphogenic, organogenic, formative state, maturation, protective, and desmolytic. The most important questions are, they can ask you 2 important questions which are very frequently repeated. One is, can you tell me which is formed first? Enamel is formed first or dentin is formed first? Yes, right. Dentin is formed first. And followed by dentin, you are going to have enamel. Okay, now the question is, in which stage dentin is formed? Dentin is formed, dentin is organized. Okay, dentin is organized. On organized dentin, enamel will start. Okay, so dentin formation occur in organizing state. Okay, now organized dentin has formed. So we have a layer of dentin on which we can load enamel. Okay, enamel is formed in which stage? Formed enamel formation. Okay, so dentin is formed. Organized dentin is formed in organizing state. On organized dentin, enamel is formed in formative state. Very important questions. Dentin is formed in organizing stage. Enamel is formed in formative stage. Clear, guys? Clear? Very frequent. This is a very, very commonly asked question. Okay, so during the initial phase of enamel matrix formation, how much amount of calcification is seen? How much amount of calcification is seen? Yes, 30%, which later convert to 100%. Very good, very good. Okay, now, so morphogenic, what happens in morphogenic? The shape of DEJ and crown will be decided. Most of the cells are short columnar with a oval nucleus. Organizing, we already told, like organizing, dentin formation begins in organizing phase. So there will be reversal of functional plurality of the cells will takes place, migration of centrioles, Golgi apparatus to the distal and takes place, where the dentin formation, organized dentin formation will start in organizing state. Formative stage is formation of enamel matrix. Matrix formation will takes place. Maturation, the word it tells, right? There, the formation of enamel takes place. Okay, during enamel maturation, the ameloblasts are slightly reduced in the number. Okay, so the maturation is going to start. Protective phase, the ameloblast layer transforms into reduced enamel epithelium. We told, right, this reduced enamel epithelium is going to protect the matured enamel. So protective means protecting the enamel which is formed, means ameloblast transforms into a reduced enamel epithelium which is protecting the formed enamel. Desmolytic, the epithelial cells, they release enzymes that are able to destroy the connective tissue fibers by a process called as desmolysis. Premature degeneration of reduced enamel epithelium may prevent the eruption of the teeth. Okay, so desmolytic enzymes are going to release to break those connective tissue fibers. That is called as desmolytic stage. So the most important stages are formation of enamel occurs at which stage? Formation of enamel occurs at which stage? Formative, right? Very good. Okay, formation of dentin occurs at which stage? Formation of dentin occurs at which stage? Organizing. Okay. Ameloblastic layer converted to reduced enamel epithelium, which stage? Reduced enamel epithelium. What is the Purpose of reduced enamel epithelium. The purpose of reduced enamel epithelium is for protection. Okay, is for protection, protective stays. Okay, so formation of enamel matrix. Okay, so that is basically due to secretion. The secretory activity starts when a smaller amount of dentin is laid in organizing state. The ameloblasts lose their projections. Okay, and separate from the predentin, and islands of dentinal matrices are deposited, and this process continues throughout the dentin on which enamel will be formed. So next one is Tomes process. Tomes process, quick fence appearance, very frequently asked question. So each ameloblast, each rod is formed by how many ameloblasts? Each rod is formed by how many ameloblasts? Yes, each rod is formed by 4 ameloblasts. One is going to contribute to the head and 3 are going to contribute to the tail. So next one is, so once the enamel matrix is formed, later half it is going to get mineralized and maturation is going to start. So enamel rods matures from the depth of the surface, and from the maturation of rods will take place from the cusp or incisal edges, and it goes towards the cervical area. Important question. Maturation starts from the cuspal tips and incisal edges, and it moves towards the cervical part. Age changes, you are very, very familiar. Enamel is formed only once. So as age increases, there will be loss of vertical dimension. That is because of your adhesions and everything. So generalized loss of enamel occurs over a period of time. And this lead to localized increasing in the nitrogen. Which ions are increased? Nitrogen and fluoride. Can you tell me which hard structure is going to have more fluoride in it? Which hard structure is going to have more fluoride in it? Yes, cementum. And among the different layers of enamel, which layer of enamel is going to have more fluoride? It is outer layer or inner layer? Which layer is going to have more enamel? Structure cementum. Cementum is going to have more fluoride because it absorbs more. So yes, outer layer of enamel is going to have more fluoride than inner layer. So there will be increasing in the nitrogen and fluoride, and enamel becomes darker, and their resistance to decay will increase, reducing in the permeability. Permeability also, reduction in the permeability takes place. Okay, right? Clear? Age changes are simple. Okay, clear, guys? Only one question I'll ask you. Okay, shall I ask? So what is the code for amelogenesis? Ammonia acid's code for amelogenesis? HPGL. Non-amelogenesis? GAS. Formation of enamel occurs in which stage? Yes, formative stage. Dentin formation occurs in which stage? Organizing stage. Specific gravity of enamel. Very good, 2.8. Dentin? 2.2. What is the type of collagen present in enamel? What is the type of collagen present in enamel? No collagen, no collagen, no collagen. Nerves, no nerves, no nerves, no nerves. Blood, no blood, no blood, no blood. Now tell me, what is the type of collagen present in dentin? Predominant collagen in dentin is, yes, recent Neet question, right? Predominant collagen in dentin is type 1. Any blood supply to dentin? Have you seen bleeding when you cut the dentin? No blood supply, no blood. Nerve supply is there? Yes, deeper layers are, no, it's not basically nerves. Deeper layers are going to have some nerve endings. Nerve supply, neural means you can tell S. Neural is S. No blood supply. Okay, neural supply is there. Okay, and type of collagen, predominant collagen is type 1. Okay, shall I go to next part? So yeah, dentinogenesis. Okay, dentinogenesis is basically dentin formation occurs from which cells? Enamel, ameloblasts, ectoderm in origin. Dentin is odontoblasts. Odontoblasts are originated from, best term is, yes, best term is neural crushed cells. Neural crushed cells. And dentin is originated from which structure? Already discussed. DP. D for dentin. P for pulp. Okay, done. Okay, I'm moving to the next one. Okay. Hardness value of enamel. Very frequently asked question. We regularly have very fantasy number. Okay. 143. 143 is related to which structure? Yeah, very good, Monica. 143 is tongue. Pharyngeal arches from which tongue is formed? 143. Enamel, you can remember 343. 343 is the hardness value of enamel. Dentin hardness value will be less when compared to the enamel, that is 80. Okay, chalo. Radiograph, you're right. It is less radio-opaque than enamel, more radio-opaque than pulp and cementum. Very simple. These are other important numbers related to the dentin. Okay, proportional limit is 148 megapascals. Compressive strength is 305 megapascals. Tensile strength is 51.5 megapascals, and modulus of elasticity value. If you want, you can make a note of it. Number-based questions are slightly less compared to last 5 years back. Number-based questions will be more. Now, the number-based questions are, I'm not telling that number-based questions are not there in the exam. They are there, but number-based stuff was slightly reduced compared to 5 or 8 years back. So histology, we have already discussed, like you have hydroxyapatite crystals, similarly like that of the enamel, but here you have collagen. The predominant is type 1, but collagen is basically absent in the case of your enamel. Okay, so it is hydroxyapatite crystals in combination with collagen. Okay, so you have this odontoblast. Okay, so odontoblasts are basically originated from the pulp, and these odontoblasts, they form the dentin. Okay, now types of dentin, most of you are familiar. Okay, the first one is called as predentin, a dentin which is very close to the pulp, which is not mineralized, and the width is 2 to 6 micrometers. Important question is internal resorption. Internal resorption is also called as yes, very good. Internal resorption is called as pink tooth. So now the question in endo is, which of the following type of dentin resorption occurs in the case of internal resorption? Which of the following dentin resorption will occur? So dentin, which is present close to the pulp, because internal resorption is basically odontoclasts are going to get activated and they get blood supply from the pulp. So which structure is near to the pulp? That is first eat away. Which structure is near to the pulp? Okay. So in internal resorption case, which dentin is first affected? Answer is predentin. Dentin, which is very close to the pulp. Okay, right. Okay, next one is intertubular dentin that forms the main body. So main body of the teeth is formed by which structure? Entire teeth, main body of the teeth is formed by, yes, very good, dentin. Dentin is going to form the main body of the teeth, and main body of the dentin is formed by intertubular dentin. Intertubular dentin is going to form the main body of the dentin. Okay, very good. Next, there is something called as peritubular dentin or periluminar dentin or intratubular dentin. Okay, dentin immediately surrounding the dentinal tubules is called as peritubular dentin, surrounding the dentinal tubules, and it is highly mineralized than intertubular dentin. How much it is? 9%. We learned one more value related to the dentin, 9%. What is that value? Dentin, one more dentin value, 9% dentin value. What is the value? Yes, moist lost. Amount of moist lost in the dentin after RC, 9%. Very good. Yes, very frequently asked question. Okay, what is the very important thing that is causing discomfort to the patient is the dentinal tubule fluid. Okay, it is also called as dentinal lymph. Any lymph in enamel? Enamel, any lymph? No lymph, no lymph in enamel, no lymph in cementum. Basically, lymph concept is not also there in dentin, but dentinal fluid, they call it as lymph. Is lymph present in the pulp? Is pulp having lymph? Dentinal fluid is called as dentinal lymph. Is pulp having lymph? Yes, pulp is having lymph. Pulp will have lymph, lymphatic supply, lymph vessels, and everything are there in pulp. Very frequently asked question about your dentinal fluid or dentinal lymph is high K, low Na. So dentinal fluid is very, very important, right? Very rich. Okay. So dentinal fluid is going to have more king. King is rich. Okay. Dentinal fluid is going to have less normal persons. Okay. Na is less. K plus is more. K plus is more. Dentinal fluid, K plus is more. Na plus is less. Clear? Done? Inside the cell, which ion is more? Inside the nerve, which ion is more? Inside, which is who is topper? Yes, very good. Inside the kingdom, who is the topper? King is the top. Okay. Inside the kingdom, who is the topper? King is the top. Okay, very good. Okay. So interglobular dentin is an abnormal dentin. Okay. Interglobular dentin is an abnormal dentin. Okay. That is most commonly seen in the case of vitamin D deficiency. Now, a little bit, I'll be talking about vitamins related to the teeth. Questions are coming. Okay. Now you have vitamin A, vitamin D, and vitamin C. Okay, tell me which are the vitamins which are useful for tooth development? Vitamins which are useful for tooth development. A, D, C. A, D, C. Okay. So A is more inclined to which structure of tooth development? A is inclined to more with which structure of tooth development? A is inclined to, sorry, A is inclined to enamel. It damages the dentin also, but it is more inclined to enamel. D is more inclined to dentin. D is more inclined to dentin, but it damages the enamel also. C is more inclined to gingiva, bone, then enamel and dentin. Okay. Now one more question, right? Gingiva, which vitamins? Gingiva, yes, vitamin C. Among A and D, what you want to add? Among A and D, both A and D are there. Which is the second one? Yes, A. Why A? A is useful for epithelialization. We remember, right? Wound healing, A is required. What is the purpose of A in wound healing is? Yes, right, epithelialization. Gingiva also requires epithelialization. Okay. Then the next one is B complex are useful. Some vitamins of B are useful for gingival growth. Okay. Gingival maintenance, gingival healing during their periodontal surgeries. The least is vitamin D. Least is vitamin D for gingiva. Clear, guys? All these are questions. Okay. All these are questions you have. Clear? Okay, chalo. So I told you, right, interglobular dentin is more inclined to vitamin D deficiency. Rickets, yes, vitamin D deficiency. So exposure to high levels of fluoride during the dentin formation can also lead to the formation of interglobular dentin. Exposure of high level of fluoride will cause more damage to enamel or more damage to dentin. Enamel or dentin? Yes, it is causing more damage to enamel because fluoride is going to love ameloblast. Okay, so ameloblast is very, very sensitive to fluoride. Okay, and ameloblast is very, very sensitive to fluoride, and enamel is going to get damaged. Okay, so when fluoride is useful for enamel, during development or after development? When fluoride is going to be very useful for enamel, during development or after development? Okay, fluoride is very, very useful to enamel after development, before development, during development. It is going to cause damage to ameloblast. Okay, it is going to cause fluorosis. So during development, Okay, fluoride with enamel will cause fluorosis. After development, fluoride with enamel leads to formation of fluorohydroxyapatite crystals, which prevents the caries, which prevents the acid dissolution. Guys, is the concepts clear? These are just simple logics. First thing, you should be logical to answer these questions. Second thing, if you are not logical, now after learning the concepts, you have to be logical. Right? Okay. During formation, okay, it is very sensitive. That leads to fluorosis. You know fluorosis, right? Fluorosis occurs very rapidly, particularly Andhra, the zones of Khammam, Guntur, and all these. The belt is more fluoride rich. Nalgonda, Khammam, and your Guntur and all these, you have more fluoride cases, right? That is during the development. After the development, you apply fluoride. That is your tropical fluoride application, your APF gels, your NAF gels, SNF2s. Okay, all these are applied because they form fluorohydroxyapatite, which is more resistant to dental caries. So apart from this high fluoride content, hypoparathyroidism and hypothyroidism, okay, are the conditions which can lead to formation of interglobular dentin. Clear? Okay. Chalo, I'm going ahead. So this is how the irregular interglobular dentins will look like in the histological photograph. Okay. Types of dentins: primary dentin, secondary dentin, tertiary dentin. Primary dentin is going to have two types: mantle dentin and circumpulpal dentin. Mantle dentin, normally dentin is going to have type 1 collagen. Mantle dentin, which type of collagen? Need 2022 question. Mantle dentin is going to have type 3 collagen. What are those fibers called as? Those fibers are called as Wonkov fibers. And Wonkov fibers, they love which ion? They love which ion? Wonkov fibers, they love not K plus. Okay. They love silver ions. They love silver ions. Okay. And slightly less mineralized than the circumpulpal dentin, that is your mantle dentin. The next comes is circumpulpal dentin, which is more mineralized when compared to that of the mantle dentin. So these comes under your primary dentin. Next comes is a secondary dentin. They contain few number of tubules than the primary dentin. That is the secondary dentin, and there will be a demarcating line between the primary dentin and secondary dentin where you can differentiate it. Next one, the important fellow, clinically more useful fellow is your tertiary dentin. Other names are different names. Okay, so it is called as reactive dentin, reparative dentin, irritation dentin, replacement dentin, or defense dentin, or adventitious dentin. Okay, these are the other names that they regularly use. The most important thing is I want you to know about the difference between the reactionary dentin and reparative dentin. Reparative dentin is formed. When reparative dentin is formed, which procedure reparative dentin is formed? Which procedure reparative dentin is formed? So whenever you do direct pulp cappings, okay, so whenever I'm going to do direct pulp cappings, so what is the golden standard material for direct pulp capping? Golden standard material for direct pulp capping. Yes, golden standard material for direct pulp capping is calcium hydroxide. The type of calcium hydroxide what I am using for the pulp capping is called as dicol, which is a fast setting, a hard setting calcium hydroxide. Okay, so that is one. And the best material for pulp capping, what is the best material for pulp capping? The best material for the pulp capping is MTA. Okay, right? MTA. So whenever you do direct pulp capping is going to trigger the undifferentiated mesenchymal cells in the pulp to differentiate into odontoblasts, and they secrete this reparative dentin. Reactionary dentin is from existing odontoblasts only, whereas reparative dentin is from undifferentiated odontoblasts. That is a difference. Very important question. Reactionary dentin is a reaction from the existing wala only, whereas reparative is from undifferentiated one. Okay, right? Clear? So age changes like dental caries, aberration, attrition, all type of your aberrations and attritions and all these things, cutting of dentin during your cavity preparation will causes changes. Those changes can be tracts, sclerosis, or you will have n-burst dentin, and all this can happen. Dead tracts, you are very familiar. So dead tracts is a recent diagram-based question in one of the examination. They are black in the transmitted light and white in the reflected, right? Okay. Sclerotic dentin is also called as transparent dentin. It is a defense reaction of the dentin that is seen mainly in the case of your older individuals. Okay. Unburst dentin. Unburst dentin will cause pain or not? A question in your operator. Unburst dentin. Yes, no pain. Normal dentin can cause pain. Unburst dentin cannot cause pain. It is regularly hard, dark in color, look like a caries, but it is basically seen in the case of which type of caries? Unburst dentin is seen in which type of caries? Yes, very good. Arrested caries. Very good. So junctions of dentin, dentin has a junction with enamel, dentin has a junction with cementum, dentin has a junction with pulp. Okay. So now tell me clinically, endoprospective, which of these junctions, okay, which of these junction is helpful to end the obturation? Which of these junction is helpful to end your obturation? Obturation should end at which of these junctions? Yes, obturation will end at DEJ. Very good. Obturation should end at DCJ. Dentinocemental junction is the junction where your obturation should end. So already discussed, there's a scalloped with convexities towards the dentin, and the scalloping will be greatest in the case of occlusal areas, that is your stress bearing areas. Coming, the next one is dentinocemental junction. So here they have given you. So this is an area where apical constructor will be there, where you are going to end your obturation. So this landmark is very, very important when you're doing obturation. Okay. And these obturation, that apical foramen, it is basically eccentric. It is not center, or sometimes the apical foramen is divided into multiple splits. Okay. So maybe sometimes you may have 2 to 3 apical foramens. So 2 to 3 apical foramens together, that area is called as what? 2 to 3 foramens, that area, that entire area is called as, yes, very good. The entire area is called as apical delta. Means it is something like a delta. So this area looks like a delta. So this is called as an apical delta. So that is, location is highly variable. It varies from teeth to teeth. That is the main thing. And this is the point at which your pulpal tissue will be converted to periapical tissue. Okay. Because at this point, until this point, you will be having the pulpal tissue. After this point, you will be having periapical tissue. Next, this complex, basically the complex of dentin-pulpal junction complex, will be learning in depth in the pulp video and everything, right? Next comes is the coronal dentin, radicular dentin. The distance between the incremental lines is more in the case of your coronal dentin, whereas it is less in the case of your radicular dentin. Extensive branches of odontoblastic process are seen here. Okay, here branching and collapsing with the adjacent tubules will occur. 4 millimeters of dentin deposition per day will occur. Root radicular dentin formation will be less. Formed by the odontoblast, root dentin is basically formed by HERS, because most of the root things are formed by HERS, which is going to contain outer enamel epithelium and inner enamel epithelium. More tubules will be there, less tubules will be there. Terminal branches of this odontoblastic process are more profused. Here, less profused. Coming to pain. Okay, what is this pain in dentin called as? Pain in dentin is called as, yes, dentinal hypersensitivity. And which theory is explaining this dentinal hypersensitivity? Best theory to explain the dentinal hypersensitivity is hydrodynamic theory. So you have 3 theories, but the most accepted theory is hydrodynamic theory. So this is a diagram that is given. So most accepted theory is hydrodynamic theory. What happens in hydrodynamic theory? Hydrodynamic theory is basically the movement of fluid. You see, we told you, right? Dentinal lymph or dentinal fluid is going to move, that stimulate the nerves, causing pain. So this is called as hydrodynamic theory. The first theory which failed is direct innervation. Means they're telling that dentin is going to have nerves, the nerves directly innervate, and these nerves are going to cause pain. But this is disproved by applying LA. You apply LA to dentin, dentin will not cause pain? You apply LA to dentin or you apply LA to pulp? So they have tried it. Okay, people are telling, okay, so dentin is having nerves. Okay, let's apply LA local anesthesia. It's not working. So direct invasion has failed. Then the next theory, the other theory that came into existence is transduction. Transduction is conduction of impulse. They're telling, like how we have discussed in CNS, there is a conduction of impulse. Means one nerve is connected to other nerve by a synapse. And how this information is being transferred? At the synapses, what is present at the synapses? A neurotransmitter is present. Okay. Then they checked for neurotransmitters in the dental pulp. No neurotransmitters are present in the dental pulp. Your transduction theory fails. Your direct invasion theory fails. So the only theory which is explaining is fluid movement is causing the pain. That is called as hydrodynamic theory. Clear? Clear? Yes, very good. Next course is hydrodynamic theory. Okay, a very frequently asked question. Hydrodynamic theory was given by I remember it as Strom, liquid, right? Dentinal fluid is moving during Strom, water will fluid. The movement of fluid will take place. Okay, that is okay. Very simple question. Important point to be noted according to. Okay, this concept slightly varies from book to book, but I just want to these are straight away lines from your Orbans. Okay, inward movement during cold stimulus. Okay, cold stimulus. What is going to happen to the fluid? For example, assume that the fluid level is this. So whenever you heat, what happened to the fluid? You take a bowl, heat the water, you heat it. When you heat it, water level raises or falls? What happened to the water when you heat it? Raises. Okay, right. So whenever there is a cold, there will be inward movement. Whenever there is a heat or drying, there will be outward movement. Simple concept. This concept, that's what I'm telling. This concept varies from book to book, but as of now, Orbans straight away they have given these lines: inward movement during the cold stimulus, outward movement during drying or doing the heat stimulus. Clear? Clear. I'm done with the major aspects of dentin. This table is very, very important. Okay, right. I told you, right? Forming cells. Whenever you have forming cells, what are forming cells? Osteoblasts, osteoclasts, active chondrocytes, hypertrophic chondrocytes, stellate reticulum we have discussed, stratum intermedium we have discussed, odontoblasts we have discussed. So all these formative cells are having more alkaline phosphatase, not ameloblasts. So ameloblasts are also formative cells. Only ameloblasts, formative cells, which are not having increasing in the alkaline phosphatase. Rest all formative cells are having increasing in the alkaline phosphatase. Guys, this table is very important. You have so many questions given from this table, like which enzymatic activity is more in the reticulum, which enzymatic activity is more in the intermedium, which enzymatic activity is more in the osteocytes, osteoblasts are very frequent asked question. Clear? Next comes the only plus is for osteoclasts. Okay, acid phosphatase is increasing in the osteoclasts. Acid phosphatase is increasing in the osteoclasts. Apart from acid phosphatase, what are the other which are increasing in the osteoclasts? There are cytochrome oxidase is increased. Okay, succinic dehydrogenase is increased. Succinic dehydrogenase, cytochrome oxidase, and acid phosphatase are increasing in the osteoclasts. Done. I'm moving ahead. Okay. Then comes to pulp. Okay. Number of pulp organs are 52, permanent are 32, primary are 20. Volume of pulp 0.38 cc, so many times repeated. Highest is going to be for molars, that too maxillary first molars. I hope you know what is coronal pulp and radicular pulp. There is something called as accessory canals, lateral canals. Okay, so they are basically formed as a break And in that break, dentinogenesis does not take place, and they lead to formation of accessory canals. And these lateral canals and accessory canals, they form blood vessels in them during this HERS formation that is helpful in the root. So the main usage of this accessory canals and lateral canals is it is going to communicate endo plus perio. That is called as endoperio lesions. Means, for example, you consider this as a teeth. A teeth is having a deep pocket for 2 to 3 years. A teeth is having a deep pocket for 2 to 3 years. Okay, you have a deep pocket, bacteria are there. Bacteria are coming. They reach this accessory canals. They start infecting the pulp. So what is this classification of endoperio lesion called as? This is primary pocket, means primary perio department wala. The next one, it is affecting the endodontic pulp. So it is primary perio and secondary endo. Clear? Okay. Now I have one more case. What happened is there is a deep caries lesion. Okay. The fellow is having severe pain, did not came to the department, did not address the clinic, taken some medication. Then it has infected the pulp, necrotic pulp has happened. Then there is a periapical abscess. Then also he did not came. Periapical abscess, then also did not came. Periapical abscess become chronic abscess. Okay. Then finally, what has happened is there is infection that is being spread from the periapical area to form a bone loss. And finally, his tooth is moving. Lots of bone loss happen. Okay. Now what is this case? This is called as primary endo friend. It starts from endo department, and secondarily it is going for a perio department with the bone loss. So it is called as primary endo, secondary perio. So these structures are very, very important. Okay. So normally most of us, we are not able to fill the main canal. We are not doing obturations and properly. So how can you manage this accessory canal? Small wala, very difficult. Okay. So these are the endoperio communications, and they are very difficult to clean. That may lead to poor prognosis. That is the reason why, okay, your accessory canals are very, very important. Okay, already concept of apical foramen was discussed, right? Apical foramen, where enamel and dentin deposition occur. Okay, as age increases, the apical foramen size decreases. Apical foramens are going to be, the size will be more in the case of maxilla, that is 0.4. Size will be less in the case of mandible, that is 0.3 millimeters. Okay, so apical foramens, it is not mandatory to be present in the central. They can be present in the lateral. That is called as eccentric. Sometimes 2 to 3 apical foramens are present. That is called as apical delta, already discussed. So this is how apical delta will be. And upon obturation, proper obturation, you can fill your apical delta like this. Coming to the functions of the pulp, after the different functions of the pulp, the most important primary function of the pulp. What is the primary function of the pulp? The primary function of the pulp is formation of dentin, which is the most important function. Apart from this, okay, one more function of the pulp is induction. Okay, what it is inducting? It is inducting the differentiation of dental lamellae and dental organ, which helps in the formation of tooth morphology, determines the tooth morphology. Formation, dentin formation, nutrition, it is giving nutrition to the dentin, protection and sensory, okay, because it has some sensations, that is pain, and it has immune cells. Lots of immune cells are present in the pulp. And defense and reparative, it helps in formation of reparative dentin, right? I told you 2 types of dentin. One is reactionary dentin. Reactionary dentin is from existing cells, okay? Whereas reparative dentin is from which cells? Reparative dentin is from cells of the pulp. The cells of the pulp, the new cells, as Pavani said, new cells are going to come from undifferentiated cells. Where undifferentiated cells are present, they are present in the pulp. They are coming from the pulp. Okay, the defense and reparative function is a function of the pulp in which it is helping dentin. Okay, so pulp, what pulp is doing? Pulp is giving food to the dentin. Pulp is protecting the dentin. Pulp is producing the reparative dentin. Okay, so it is helping in all the ways to the pulp, like a good friend. Okay, so very close friend, right? So pulp is associated with the dentin, so pulp is doing its job in protecting the dentin from all the areas. Okay, I told you pulp dentin complex. The pulp dentin complex is going to have 4 layers. So once you come from the center is called as core, that is called as core pulp. After which you are going to have rich zone, cell rich zone. Then you are going to have cell free zone. The outer layer is called as odontoblastic layer. Clear, right? They can ask you from center to out, outer to in. Okay, so odontoblastic layer is present in the periphery. Okay, so whenever you're stress free, cell free means stress free, you will be well. Easy to remember, right? Okay, then you have cell rich zone. Rich people are high H. Rich people are high H. Okay, right? And the center one is called as core zone. Very simple, nothing very too heavy. So odontoblastic layer is very, very simple. It is peripheral layer. And the odontoblasts are tall columnar cells in the coronal pulp, and they gradually become flatter as they move to the radicular pulp. Okay, the cells are arranged in palisade pattern. Very simple, nothing too heavy. Then comes the stress-free. Stress-free. Whenever you're free, well-being will be more. This is called a cell poor zone also, approximately 40 micron thickness. Okay, and here you don't have cells, no cells, cell-free zone, right? No cells, but cell extensions will be there. No nerves, but nerve extensions will be there. Okay, cell extensions, no nerves, nerve extensions. Okay, the nerve extensions are called as plexus of Rashko. Okay, the fibroblast extensions are called as cytoplasmic extensions of fibroblasts will be there. Here it is cell-free zone, but no cells, but extensions will be there. So this, basing upon the functional activity of a particular pulp, you can know the presence of cell-free zone or not. So this cell-free zone may not be seen in the case of young pulp or may not be seen in the case of old pulp, because young pulp, there will be rapid formation of dentin. Old pulp, there will be continuous formation of reparative dentin or reactionary dentin that can be takes place. So that is the reason why cell-free zone is minimalistic in the case of your young people and in the case of your old people. Then comes the cell rich zone, because it contains lots of cells. It is high in the case of coronal pulp. You have fibroblasts. What are the predominant cells in the pulp? Predominant cells in the pulp. What are the predominant cells in the pulp? The predominant cells in the pulp are fibroblasts. What are the predominant cells in the gingiva? Perio question. What are the predominant cells in the gingiva? What are the predominant cells in the gingiva? Yes, answer is same. What are the predominant cells in the PDL? Periodontal ligament. What are the predominant cells in the periodontal ligament? Answer is same. Okay, so right. So you have predominant cells and you have undifferentiated mesenchymal cells that can be differentiated into any type. So what are the pulp cells are called as? Pulp cells are useful for stem cells, right? Pulp stem cells, pulp stem cells, which we have discussed in regenerative endodontics. Okay, right? So pulp stem cells are basically used in regenerative endodontics. What are these types of cells? Pulp cells are called as DPSC, dental pulp stem cells. What are their property? What is their property? Yes, someone is telling TOTI, not TOTI. It is pluripotent cells. Pulp cells are called as pluripotent. P for P, easy to remember. Pluripotent, right? Don't get confused. Okay, P for P, pulp cells, useful for regenerative endodontics. So pluripotent cells has a capacity to give rise to many other types of cells. Like the pulpal cells can be used in your stem cell banking. Okay, they can give rise to nerve tissues. They can give rise to pulpal tissues. They can give rise to many other tissues. Okay, right? So P for P. Okay, the next comes is, as I said, like fibroblast. Okay, so what are the types of fibers which are present in the pulp? One is elastic fibers, okay, which are surrounding the blood vessels. Second one is collagen fibers. What type of collagen fibers are present in the pulp? Enamel, no collagen, dentin, type 1, pulp. Yes, type 1 and type 3. So which is predominant? Type 1. Type 1 is 55%, type 3 is 45%. Sorry, if I'm asking fetal pulp, which type of collagen is present in the fetal pulp? Yes. Collagen which is present in the fetal pulp is type 3. Similarly, means type 3 will be converted into type 1 in the future. Any such phenomenon occurring somewhere? I have discussed general pathology. Type 1 converting into type 3. Yes, Gayatri, very good. Wound healing. So wound healing also, the initial type of collagen that we regularly see is type 3. Later, the type 3 will be converted to type 1. In the pulp also, fatal. Initially, it is type 3. Later, it is converted into type 1 and type 3. Right. So where do you see type 3 collagen? Normal, I'm asking. Where do you see type 3 collagen? Yes, one very good answer. Shravani. Mantle dentin, Vankov fibers, reticular fibers, very good. Reticular connective tissue. You have type 3 collagen. Any disease having abnormality of type 3 collagen? No. Alpert's is type 4. Sorry. Alpert's is type 4. Yes, it is Rubberman syndrome. Which type of Rubberman syndrome? Not all Rubberman syndromes. Which type of Rubberman syndrome? Yes, type 4 Rubberman syndrome. He is having an abnormality of type 3 collagen. That is called as vascular type of Rubberman syndrome. Okay, here reticular tissue will be damaged because reticular tissue helps in blood vessels, formation of blood vessels. So this fellow is going to have vascular problems. Okay, so the most dangerous type of EDS, the most dangerous type of EDS is type 4 EDS because they have more chances of death. Okay, done. So in young pulp, we already discussed type 3 will be more. So young pulp, normally single fibrils will be there. As age increases, what is going to happen? As age increases, the vascular content decreases, means the cellular content decreases, the fibrous content increases in the pulp become more fibrous. Okay, greater concentration is found in the most apical portion when compared with the coronal middle 1/3. Apical portion is going to have more collagen. As age increases, collagen increases. As you move from top to bottom in the apical 1/3, the collagen will be more. And this is the phenomenon which is used by most of our young endodontists as well as the young dentists, right? Whenever they open a new clinic, whenever they start doing RCs, okay, they keep this photograph. Okay, right? What is that photograph? They remove the entire shot of pulp. Okay, and they keep the photograph. What is the instrument which is used to remove that entire shot of pulp? What is that instrument? That fellow is the root canal instrument, which is more prone to fracture. Instrument which is more prone to fracture. Yes, right. That is called a bar brooch, which is more prone to fracture. So what they do is they insert this bar brooch deep into the apical 1/3, because apical 1/3 concept, what we learn is apical 1/3 is going to have more collagen. So I'm going to engage those collagens in my bar brooch and I'm going to remove the entire pulp in a single shot. That is what the mechanism there. What is the mechanism? Which part of root is having more collagen? Which part of root is having more collagen? Okay, it is apical 1/3. Okay, apical 1/3. Which part of root is more prone for file separation? More prone for file separation. Very good, apical 1/3. Collagen is more in apical 1/3. Which part of root is more important for an endodontist? You divide 3 parts. Which part is more important for an endodontist? Yes, it is apical 1/3. Which type of root fracture has more prognosis? Which type of root fracture has more prognosis? Yes, apical 1/3. Okay, right. So this is again a diagram that is taken from your Ingle. So there was a study that is done comparing your blood flow rates in different parts of the body in comparison to the pulp. The blood flow rate is high in spleen, followed by heart. Very important physiology question. Blood flow rate is high in spleen, followed by heart. Then comes the intestine and brain. Okay, pulp is coming after the brain. Okay, very, very important. The sequence they can ask in sequence-based questions, INI, CET, or Neet, they can ask you. So before going into that, we'll be discussing about the pulpal pressures. So what is normal pulpal pressure? Yes, normal pulp pressure is 5 to 10 millimeters of Hg. If they're asking about Hg, if they're asking saline or water, what is your answer? If they're asking saline or water, then your answer is 10 to 15 centimeters of saline or water. So whenever there is increasing in the pulpal pressure, pulp is a closed encapsulated cavity, right? Closed by dentin from all the sides, it's going to cause pain. So what is going to be the pulpal pressure in the case of reversible pulpitis? 13.5. Irreversible pulpitis? 34.5 mm of Hg. There is one theory called as Steeling's theory. What is the Steeling's theory? Steeling's theory is going to determine the pulpal blood flow influenced by the vascular tone of the adjacent tusk. Like you have pulp adjacent, what you have? You have gingiva, you have PDL. So how this is varying? Like for example, there is a vasodilatation. You do something, you cause vasodilatation in the adjacent tissue. Okay. That lead to compression of the pulpal blood flow. When you cause compression of the pulpal blood flow, there will be drop in the blood flow. So then the pulp will be in a state of shock, like how we have decreasing the blood flow. The pulp will be in a state of shock, but pulp is having an internal quality, okay, that it is going to reduce the pulpal perfusion by it's going to maintain its viability for some time. Like for example, we regularly do these manipulations, right? Whenever you keep this matrix band, okay, modify the pulp, you cut the gingiva, pulp is going to get the blood supply from all these areas through the apical foramen. So this concept of how pulp is going to get compromised because of the manipulations in the adjacent tissue are explained by a theory called as Steeling's theory. Right? Clear? Don't go very deep. It is a PG concept. For an UG, this is more than sufficient. Okay. Then I'll be talking about the nerve supply. What are the nerves which are present in the pulp? So nerves which are present in the pulp are the predominant nerves which are present in the pulp are C fibers, followed by A delta fibers. Any other fibers according to Engel? It's going to have A beta fibers also. But make a note, beta fibers are not going to cause any pain. So I'm least bothered. So beta fibers are not going to cause pain. The only fibers which are causing pain are C fibers, A delta fibers. The entire body, what are the pain causing fibers? Not in pulp. Entire body, what are the pain causing fibers? Alpha fibers will not cause any pain. No. Same. Okay. Same. A delta and C fibers are the pain causing fibers, whether it is a pulp or. Now, if I'm asking fastest fibers, velocity is fast in which fibers? Normally, velocity is fast in myelinated fibers. Out of the fibers, velocity is fast in A alpha fibers. If I'm asking what are the fibers which are having maximum velocity in the pulp is, it can be A beta or A delta. Predominant fibers are C fibers. C for C, C for C, C for center, C for core. Fibers which are present in the core, fibers which are present in the center are C fibers. These are unmyelinated fibers. Fibers which are present in the periphery are A delta fibers, which are myelinated fibers. And in most of your pulp sensibility tests, that is your EPT, heat test, cold test, what you are going to measure? Mostly, what fibers you are testing? You are testing A delta fibers or C fibers? Yes, you are testing A delta fibers. There is one concept in pedo, right? In pedo department, in primary teeth and permanent teeth, primary teeth and permanent teeth, pulp sensibility tests are contraindicated. Why? In primary teeth and young permanent teeth, pulp sensibility tests are contraindicated. The reason is there is no myelinization. Normally, myelinization is going to occur 4 to 5 years after the eruption of a teeth into the oral cavity. So there is a problem with A delta fibers because A delta fibers are the only myelinated fibers. They are not properly myelinated in young permanent teeth as well as in the primary teeth. That is the reason why pulp sensibility tests are contraindicated because there is no development of A delta fibers properly. A delta fibers are going to take 4 to 5 years after their eruption into the oral cavity for their formation of myelin sheet on them. So among these fibers, which are the fibers which are more, they react fast to the local anesthesia? They react Yes, they are C fibers. Let it be C fibers present in the center. C fibers does not have any myelin sheet on them. So as they don't have myelin sheet, they react fast to the local anesthesia. Very beautiful, important points were given related to the microvascularity of the pulp from your organs. So whether it is arteries or whether it is veins, they are thin-walled in the pulp. And make a note, pulpal arteries are as big as arterioles elsewhere present in the body. Can you tell me what is the number, thickness? Anyone? Dimensions which are given in the organs? 50 to 100 microns. There is no branching in the radicular pulp. Subodontoblastic plexus of capillaries are seen. And these capillaries are seen. These capillaries are seen, right, throughout the pulp. Even they are seen in the case of your cell-poor zone, that is your cell-free zone also. Okay, the next one is concept of pericytes and sympathetic nerves. Sympathetic nerves and pericytes, they control the blood flow. Very important point. Both of these, they control the blood flow. High capillary pressure is seen in the pulp. We have already discussed 5 to 10 millimeters of Hg or 10 to 15 centimeters of saline or water. Rapid blood flow and fenestration capillaries are also present. Okay, right? That's again a question. Fenestration capillaries, which type of capillaries in the pulp helps in transformation of metabolites? The answer is fenestration capillaries. The answer is fenestration capillaries. I told you lymph is there. Lymphatic flow follows the course of the blood vessel. I told you lymph is there in the pulp. Okay, whereas your dentinal fluid is called as dentinal lymph. Pulp is also having the lymph. Then comes it's a physiology concept basing upon the semi-permeability. Capillaries which are present in the blood are basically divided into fenestration capillaries, continuous capillaries. These are the two types of capillaries which are present in the pulp. We want fenestration capillaries because fenestration capillaries helps in transformation of metabolites in the pulp. Very important, fenestration capillaries. The third type of capillaries which are not present in the pulp, but physiology concept, they are discontinuous capillaries. And the fourth one are tight junction capillaries. Type 1 and type 2 are present in the dental pulp. That's what we have discussed. Fenestration capillaries are type 1 capillaries, which helps in transformation of metabolites through the pores which are present in their capillaries. Clear? Clear. I want your quick response. Then comes the next one is pulp calcifications. Okay, pulp calcifications also called as pulp stones. So what type of calcifications you regularly see in the pulp? Recently done general pathology. So you have two different classifications, metastatic calcifications and dystrophic calcifications. Dead and degenerated are associated with the dystrophic calcifications. So dead and degenerated. So pulp is going to have some dead cells where the calcification will occur. So type of calcification that is seen in the pulp is called as dystrophic calcification. Can you tell me what are the serum calcium levels in dystrophic calcification? Serum calcium levels in dystrophic calcification. Very good. Normal. The answer is normal. What is serum calcium level values? Value of serum calcium level. 9 to 11 milligrams per deciliter. Tetany, in tetany, what is the value? Tetany, it is less than 6 milligrams per deciliter. So yes, you have different types of pulp stones: true, false, fine, defined, free, attached, and embedded. And sometimes the pulp stones can appear as snowstorm calcifications, like tiny spicules throughout the pulp. So they are called as pulp stones. So please do remember this tagline. So which irrigation solution you are going to use in the, whenever you have calcified canals, whenever you have pulp stones? EDTA. What is the pH of EDTA? Very good, 7.3. Percentage of EDTA? 17% of EDTA. Very good. Endo integrated content. Multiple pulp stones are seen in. Multiple pulp stones are seen in which condition? Yes, Rubberman EDS. Multiple sinus openings on the face are seen in which condition? Multiple sinus openings. Yes, multiple sinus openings with sulfur granules are seen in the case of actinomycosis. Okay. What is the drug of choice for actinomycosis? Very good. Penicillins. Very good. Any colonies? Any colony type? Molar-like colonies. Molar-like colonies are seen in actinomycosis. Spider-like colonies are seen in actinomycosis. Ray-like colonies are seen in actinomycosis. Okay, right. So it's already hitting 8. So I want to close the session. Okay, hope this sort of integrated revision is useful. I need your response regarding this. So we'll be taking many more sessions, like quick revision, fast revision. Okay, so if you feel it's a little bit fast, the recorded version will be available on the website. A few demo classes will be posted on the YouTube. And I hope you know how to decrease the speed. Okay, right? I mean,